and I'm not used to that. No. I'm just starting the stream, but now I don't want to start the stream.
So you bring all the speed to pretend how to recover. I can.
I'm not even gonna draw.
Yeah, so you got you're all right. Yeah. I understand. Like it's hard for all of us to zoom out once in a while. But I get it. You've been at the end of that boat for a while. Yeah, exactly. It's exactly. It's hard to take the view. You can't just like be unemployed for a couple months just because they're for sure. Yeah. Even with this, like I'm trying to do only projects that I like or help film people's acts because that's more of an active service and it pays a little bit. But I don't understand. I did social media during the pandemic, like with the juggling class, and hated it. That was like it felt like the definition of selling out. I was like using all these skills to make things that I didn't really like, and it ruined this thing that I really enjoyed, which was creating what this is about. So it's an easy swing to go. Even now that I have like a split income stream and I don't have to rely on one or the other, it actually makes the balance really, really nice. It keeps both of them. I would love to get to that point where nobody can dangle a contract over me. Like I know you need that. Jump for it. Word. Yes. Yeah. And then it's fixed for the rest of it. blind man. Yeah. Yeah, enterprise-ish ring. Okay. So Rotary. Okay. Dude, the pitch price for the rail though is ridiculous. It's like $200. $400 like round trip or something like that. And it's like you can fly for $100 or $200. Yeah. So, and it doesn't even go to LA proper. It goes to what? You guys hear about, I can't remember what step like the studio that Mark Wahlberg wants to go to. It's in Summerlin. It's like a $1.2 billion studio. It's in California. There you go. Fair enough. Man, I actually, the stuff I'm shooting with Jill is gonna really freaking it's fun, but it also, she's still connected to being in the music industry. Like, she was signed for a couple of years in Nashville, so when she posts things, it's getting attention to the right people. I'm really excited about it, because it could be just one of the opportunities, some live show concepts that we're testing out too, that I'm really stoked about, and that's like, my main mission would be to help creators direct production. That's what I would do. Definitely, it's gonna be stoked. Yeah, I'm going to Orlando in the summer to do train calls. Yeah, for sure, man. I gotta do my job anyways.
going to be talking today about aesthetics and well-being. And so I'm going to have everyone help join me in welcoming Dr. Isaiah Lynn.
All right. I suppose I should address the elephant in the room. Can I, real quick, can I get a show of hands? Who's sort of a doctor, a healthcare professional? Okay, and who's circus performer, athlete? Okay, anybody not in either? Okay, awesome. Any philosophers? Okay, that's perfect. Yes. Okay, love it. All right. So I'm a little bit fish out of water here, but I'm really excited to be here. I want to share some of the things that I've been thinking about for the last couple of years. And I'm mostly here because I'm excited to hear what some of you have to say about it. So first off, thanks for putting such a cool program together. I'm really excited to be here. Let's just jump in. So I want to say a little bit about the origin of the project, how I sort of stumbled onto this view that I want to put on the table for you to consider. It started when I started reading and got really interested in the philosophy of art. So I started thinking about what art is, what beauty is, where aesthetic value can be found. I started reading a bunch of philosophers who wrote about this sort of thing. Sort of coincidentally and sort of entirely unrelatedly, I was reading about well-being. So I was doing a little bit of classical philosophy, thinking about ethics and value theory, and of course, philosophers have thought for a very long time about what makes for the good life. And at some point, I realized it struck me as that it might be a mistake to be having those kinds of conversations independently of one another. That really those kinds of conversations should overlap. Questions about aesthetic value really should touch down in questions about what makes for the good life. But weirdly, contemporary analytic philosophy, at least, those literatures are somewhat insulated. So I thought that was problematic. So at least my suspicion is that everyone would benefit from sort of getting together and talking, and I'm excited because that's sort of what's going on here to an extent. So I'm sure this kind of problem you're all familiar with. Probably people in the medical profession are among these people. You recognize that maybe people in one specialty are sort of ignorant of what's going on in another specialty, and it really takes a deliberate effort to bring the knowledge together into a sort of cohesive body of knowledge. So I'm sort of in the beginning phases of trying to articulate where precisely I think the overlap is. Where it is, I think, that philosophy of art and well-being sort of come together. I don't really know, I don't have a stake in the game, but I have suspicions, I have pet views that I think are interesting and worth taking seriously. But I'd love to hear what you have to say. So my aim is pretty modest. Maybe in a different context, have my philosopher hat on and be ready for war and some aggressive objections. But if you leave here more curious about art and beauty and the good life, I think I'll call that a success. Yeah. Okay. I'm going to do my best. I know Nate just said these are going to be longer presentations. I want to do my best to keep it as short as possible because selfishly, I want to have a conversation with you all about some of these ideas. So the more time we have for Q&A, the better. Okay. All right, so here's the rough outline. The first part will just be kind of a summary of some of the things that I read about and sort of distilled in the philosophy of art, and a bunch of different views about what initial answers we have are sort of unsatisfying and are worth philosophical reflection. So here's some of the questions I think are really pressing. Where is aesthetic value located? And relatedly, what ultimately is the thing that is beautiful? If we can figure out where aesthetic value is located, as is the case for any resource or good, we'll be in a much better position to acquire more of it if we want. We'll also be in have a better sense of what kinds of personal projects are worth undertaking, what sorts of social systems might be more or less valuable, at least in an aesthetic sense. There is, of course, a very interesting question in the philosophy of art that maybe you're particularly interested in, which is whether or not there is such a thing as beauty or such a thing as aesthetic value. I think that's an interesting question, but I have to confess I'm not particularly moved by these kinds of concerns in the background. I take it as sort of self-evident that there is such a thing as beauty. So for the purposes of this project, I'm going to take that for granted. And so to me, the question, so I know many of you are working in the empirical sciences, you have the scientific method. Philosophy is, unsurprisingly, not like this. We read old books in dark rooms, and we argue with each other and sit in armchairs and smoke pipes. That is a true stereotype. So I work in the analytic tradition, sort of comes out of Frege work in recent times. The field has sort of undergone a few different changes. So there's different ways in which philosophers go about trying to do their research. In the 50s and 60s, it was largely a kind of project people call conceptual analysis. So you might ask the question something like, what is it, questions about personal identity, what is it for a person to stay the same person over time and through change? And people that are working with this kind of tool, they're interested in meanings. So the key question, the key philosophical question is something like, what do we mean when we say that people, we re-identify people or persons over time? What are we saying when we say that that's the same person over time? The question is sort of fundamentally linguistic. It's about the meanings of terms. In the sort of 70s and to the 90s, there was a sort of a big shift. Philosophers started thinking primarily with what people call modal tools. And so that's the kind of question or method I'm going to play around with today. The basic idea is, if we use the same example, the question is, what are the conditions that govern personal identity, that sort of hold of necessity? For example, we might be interested in the question, is it possible for somebody to lose all of their memories and stay the same person? Notice the question there is about what's possible, not about the meanings of terms. So, sort of classically understood, this is a metaphysical question, not a language question. So, yes, the tools have changed, the way philosophers have been thinking about these things or trying to make progress has changed. I'm just going to, there are other ways to make progress, but this is counts as a lot. Yeah, pretty straightforward. Obviously, some of these can be trickier, right? Some of these things are going to be contentious. If I were to ask you to give me an analysis of sport, I suspect many of you would give me a kind of analysis that differed from many other people you might ask out there on the street. So even if the project is going to be tricky or contentious, hopefully you get a sense for how the game is played. We're looking for conditions under which something qualifies or satisfies a concept, and then we can test that against counterexample cases. So, somebody might say, what is a sport? And somebody might say, well, here's a condition, it's got to be physical, right? And somebody says, or maybe somebody says, oh, it's got to involve a ball, right? Like, what about Greco-Roman wrestling, right? So counterexample. So there's a kind of back and forth as we look for an acceptable analysis. All right, so philosophy of art. We go back quite a ways, and we start to see a view that identifies representation, sort of loosely speaking, as the key criterion. Here's what extracts, which is both of them seem to agree that art is imitation. So art is imitation. So if we're playing the modal analysis game, we could try to hypothesize that art is imitation. That's the condition. Something is art only if it is imitation. Now, obviously, we think that this is a highly implausible theory of art because it's too limited. It excludes art that's not imitative, and there are surely lots of non-imitative art. In some ways, we should be understanding because the art of the time was sculpture, right? Theater. It was largely imitative. And they still represent, they're still identifiable, but they're not meant to be mirrors to reality. That's not the aim. So representation is a broader aim. Okay, so you got a second attempt. X is R if and only if X stands for Y. It's sort of representational in some way. Of course, this still seems too strict to us where we stand now. Not all art seems representational in that sense. Another final view in the representational sort of camp is the neo-representational theory, which once again weakens the claim to include more things as art up and sits there for that amount of time. That's the whole piece. A lot of people are like, this is ridiculous. That's a pretty natural reaction. But you know, if you can put the hat of the person that likes neo-formalism on for a second, you can start to see what's artistic about it. Okay? The idea is there's a content, there's something that maybe the artist wants to say, maybe the thesis is something like the ordinary sounds of life are worth listening to with the same kind of intention that you would listen to concert pianists with. And so the idea is that, like, you know, the coughs in the room and the squeaking of the chair, those things end up being something like the art piece, right? But the idea is there's some fittingness between the form, the presentation of that content in the concert hall with somebody sitting at a piano and it being silent, that fits the thesis of, you know, ordinary sounds are worth listening to carefully, right? So art is what you get, again, when form and content fit appropriately. Maybe you think it's a crazy view, that's fine, but that's the idea. Okay, so quick recap. There are of course, other views. I'm just presenting a few of them here. Imitation theory, representational theory, neo-representational theory. Those are all sort of part of the art as representation camp. We have expression theory. Right? Art is about emotional communication, and then formalist views, where it's about the formal features of the art piece, maybe neo-formalism about fittingness between form and content. What I'm hoping that maybe we'll get a sense of is we'll make this kind of observation that all of these views are in some sense object-oriented. Even expression theory is going to be object-oriented in some sense. So let's recall our key question. Okay? The question that sort of got me interested in this topic was, where is the aesthetic value? Like, where is it located? What sorts of things bear the aesthetic value or beauty more generally? Bury the lead anymore. Here's a view that I kind of like. So, aesthetic experience. So we can call these aesthetic theories of art that see art as irreducibly subjective in some sense. It's about the experience of the art. And proponents of this view think about artworks as affording us a certain kind of experience. They generate in us a kind of contemplative state. That state, which we can call aesthetic experience, is the point of art. Art is the artwork itself as such. It's just a device, it's a tool or medium by which we secure those experiences. So we might sort of try to characterize it like this. X is art if and only if X is produced with the intention that it possessed the capacity to afford aesthetic experience. So here's one key insight, is that we shouldn't understand art in terms of what it is, but what it does. If we think about all those other views, it's about whether or not it does a good job representing, like portraiture, right? If you're on the imitation view, does it do a good job representing the person you're painting, right? What about these formal features? Does it fit the content well? You're talking about the object, right? Here we're thinking about what it does in us. This is a kind of functionalist account of art. Functionalism is given in many different kinds of philosophies. There's a distinction you might make between structural and functional concepts. If I were to say, what's water? Right, you'd probably tell me that it's H2O or something like that. Your sort of understanding of the thing is given in terms of what it's made of. But if I asked you what a doorstop is, and you're like, yeah, rubber, that seems like a mistake. You understand what a doorstop is in terms of what it does. A doorstop stops doors. We don't really care what it's made of. Right? So the move here is to say, Stop trying to understand art in terms of what it is. Try to understand it in terms of what it does. Okay? So here's another maybe general kind of social vision. Think about nails. I mean, there's limits to the analogy, but think about nails. We buy them to nail things together. Hardware stores stock nails, so people who have that goal can go get what they're looking for. The manufacturer of the nails who supplies the stores intends in making the nails to facilitate the goal of nailing things together. And the best explanation for that social nexus among nail makers, hardware stores, and nail users, or that is the best explanation, right? That's the reason why, in some sense, people are making nails, to facilitate that goal. Similarly, if we use artworks to secure aesthetic experiences and seek art out for that purpose, then it stands to reason, by analogy, that in some general sense, artists create things that function in ways that are conducive to us realizing that goal. That art serves to allow us to have those kinds of experiences. In some way, it should be unsurprising that we really value museums. And sort of on this way of thinking about things, it's kind of like an aesthetic buffet. Yeah? It's just an opportunity to encounter many different things and attempt to achieve aesthetic experience over and over. Okay, moving on. So that's one literature, right? So that was like this thing I was reading about. I was curious about this question. What is art? Where is it? Reading about some of the views, trying to figure out what I think is plausible. Ended up thinking, the aesthetic experience view seems pretty good, right? At least there's something that resonates with me about it. There's another sort of very popular debate in philosophy about well-being. First, I suppose I should be really clear about what I don't mean by well-being. I don't want to be misleading anybody here. Many of you are in healthcare or medical professionals, so the notion of well-being you may be understanding as a kind of biological notion, sort of biological well-functioning, maybe more broadly to include psychological well-being and so on. The philosophical notion of well-being is supposed to be even more fundamental. Right? Might well include biological well-being, but we're looking for fundamentally what the good life consists in, whatever that might mean. Maybe that means psychological well-being is relevant, maybe not. Everything is open. Okay? So here's the take, or the intuitive beginning. If I were to ask you, what sorts of lives are good for an individual? What would you say? What does the good life look like? Right? When would you say that person's life is going really well? Something like that. If I were to ask you, what kind of a life do you want for your child or a loved one? What would you say? That's what we're looking for. We're looking for the sense in which something is good for, a life is good for the person who lives it. And the key notion of well-being is we're looking for intrinsic, sort of something, we're looking for non-instrumental value. Of course, a life, with financial means is going to be valuable, but instrumentally, right? What it can get you. We're looking for things that are intrinsically valuable. Here are the dominant views. Most people today endorse hedonism or desire theory, desire satisfactionism. Hedonism obviously has been around a long time. The basic idea is the extent to which somebody's life is going well is just to be understood in terms of the amount of pleasure or happiness in that life. Okay. So how many kinds of things are intrinsically valuable? One, pain and pleasure. Right? So you want to know what sorts of life is good? I want lots of money. Why? Well, because I can use that to make me happy. Why do you, what kind of a life is good? Well, I want to, hit a Grand Slam in the World Series or whatever. Right? Why? Well, that would make me happy. So there are lots of things that are valuable, but the hedonist thinks all of those things that are valuable are only valuable insofar as they provide us with pleasure. So you understand well-being fundamentally in terms of the pleasure that you derive from all these things, the human experience. Desire theory is pretty similar, but importantly different. The desire theory says, I agree, there's only one thing that's valuable in life, and it's the satisfaction of our desires. So I've got many desires. I was hungry a minute ago, but I got to satisfy that desire. So that's good for my life. So somebody's life is going really well to the extent that their desires are constantly being satisfied. To the extent that they're being frustrated, that's a really bad life. Now, you might think there's obviously a connection between the satisfaction of your desires and hedonism, right? The pleasure and pain in life. But the question is, what's doing the work? Right? Imagine a case where you get all the things you want, right? Desire. You get all the things you want, but you're miserable. Your life is full of suffering and pain. Yeah. Is that a good life? Desire satisfaction says yes, because the good life consists in satisfying desire. Now, similarly, imagine somebody who's really happy all the time, but they get none of what they want. Maybe they're just happen to be a happy person sort of by disposition. They got all these goals in life, and they achieve none of them. Is that a good life? So the hedonist says yes, because well-being is measured by happiness, not desires. For the most part, in analytic philosophy today, people hold one or the other of these views. The minority view is what people call an objective list theory. There are some people now who say, look, I get that pleasure or satisfaction of your desires makes for a good life, but I'm not ready to say that those are the only things that matter. There are other things that matter. One of the most famous versions of objective list theory, or reasons to reject hedonism and desire satisfactionism, comes from certain kinds of trajectory arguments. So imagine this, I don't have a whiteboard, but imagine just a graph, right? Sort of where your x-axis is time, and the y-axis is just how much happiness or pleasure is in that life. Imagine starting at 0, 0, starting at the bottom left, and just drawing a 45-degree line. Yeah? The life, as time goes on, gets happier and happier. Yeah? Now imagine another life that starts off really, really happy, and it gets worse and worse. It gets less and less happy, and then at the end of life, 0. Raise your hand if you would prefer the second life. Yeah, intuitively, nobody would say they would rather live the second life. That's not preferable. But notice, they have the exact same amount of happiness. No. One just starts off very unhappy, but ends up really happy. The other one starts off really happy and ends unhappy. But in terms of the amount of hedonic pleasure, we're just stipulating it's the exact same amount. So the hedonist should be stuck. Be like, well, I guess they're equally preferable. In terms of well-being, they're the same level. But our intuition says no. And if you think about why, a lot of people will say, well, it's about the shape of the life. It's about the trajectory of the life. There's something valuable about the trajectory, independent of how much happiness is in it. Once I sort of started reading about trajectory arguments and the shape of a life mattering, well, now this is where I started to get sort of suspicious of thinking that there's a kind of overlap. If you think that there's value in the shape of a life, that strikes me as a kind of aesthetic notion. That strikes me as you caring about the story of your life, something like that. Right? There's something preferable about your life starting off in the pits and becoming really happy and ending that way rather than the other way around. That makes for a worse story, right? Something like that. But that's aesthetic. So I'm sort of now, reading these two sort of disparate literatures thinking, I don't think we should do well-being in this philosophical sense, independent of us having views about where the aesthetic value is and what it is and all the rest. All right. So really quick, I just want to sort of present the view that I have in mind, and then let you tell me about why I'm wrong. Here's the very straightforward articulation of the view. Let's try to make the connection between the two conversations explicit. Here's at least one point of contact. We've got good reasons, I think, to endorse an aesthetic theory of art. If that's right, aesthetic value isn't out on the canvas or the wall. It's not coming out of the piano. It's not being projected onto the silver screen. It's inside of us. The properties of light, sound, etc. are out there, but the value isn't. Value is bound to our conscious experience. our conscious experiences are the proper bearers of beauty. So the key question was, where is the value? I think the value is tied to our experiences. It's no longer whether art is good for us, but only whether the value it provides is instrumental or not. Remember, the debate in the well-being literature is about what's intrinsically valuable. We might yet be hedonists if we think, yes, there's aesthetic value, yes, it's had by our conscious experiences, but those things only count as valuable because, what are we left with here? Suppose you drink the Kool-Aid. Right? Suppose you buy what I'm selling. I think there's a bunch more to think about. They deserve it. All right. Here's the conclusion. I heard people were putting pictures of their children on here, so here you go. That's my son. He's adorable. If you ask him, if you say, "Show me happy," there's a 50% chance he does that. All right, there you go. So I would love to hear what you have to say.
Okay. I'm going to let everyone think about any questions they have. I'm going to start off. I have the joy of being the moderator, so I get first question. But as everyone thinks about that, my question, Isaiah, is you talked a lot about the experience that art and beauty invokes in people. And so my question, as we've had a lot of performers and a lot of people that produce art of certain kinds, will have a problem sometimes where people won't appreciate the type of art that they are doing without either a knowledge of it, an experience of it. I think for all the performers in the room, you've all done a skill that's like the hardest skill you're doing, and everyone's dead silent, and then you do a spin really fast and everyone claps really loud. Is there a point, if you were to drink the Kool-Aid in this, to state that there's a...
Here are a couple of things. What's valuable in an aesthetic sense. So that's perfectly compatible with any...
As you did today. But I was, as far as I understood, you defined aesthetic value as something that is common and general, which from my perspective, it's very hard to assume because value will itself, like you said, be subjective. People will have a subjective view on the aesthetic value of something. And moreover, if I remember the definition correctly, it had something to do with the artist's intention of generating this movement in the audience. And I'm not sure of the order of the definitions, but back and forth. Wouldn't you say that's also a very restrictive way of matter, of restricting the possibilities of what art actually is, because you're implying there is some intention, you're implying that there has to be some effect that is common, which is very hard to have a common effect in a heterogeneous audience, if you understand what I mean. And so, yeah, how would you address this?
Yeah, that's a great question. So here's how I would address it. So the definitions or the analyses, the modal analyses that I sort of threw on the board under each of those views, there's wiggle room, right? So these are, you should think of them as kind of families of views. Okay, so maybe a more accurate way to think about it is there's approaches to art that think about art primarily in terms of representation. So there's the imitation, representation, neo-representation. There's families of art that think primarily in terms of art in terms of emotional communication. Right? And then there's kind of formal art, or formalism. And the view that I had in my aesthetic theory is, yes, so the one that I put up there does have an intention, but it doesn't have to, right? The general idea behind aesthetic experience is that the focus of art is on the experience of the art, right? So it's an approach to art, a functional approach to art, where we try to understand it in terms of what it does. And so it's not essential to the family of views to put the intention part in there, but that is one of the views that somebody, an aesthetic theorist, does have. But we could throw it out, and I'm open to that. Yeah.
So, okay. So how do I phrase this? So, I find in performance art, often, as was said earlier, you'll find that if you get overly technical or overly this or that in what you're doing,
then the majority of people are not going to understand what they're looking at. You know, as you were saying with the, sorry, I'm a terrible daughter. What you were saying with needing to build an understanding of what you're looking at to be able to appreciate it. That being said, I found in my own performance when I built myself in a way that is aesthetically pleasing, I believe, to a wider audience, but is not able to identify that. Would you find that carries over in what you're talking about? Like you say, this is good. This is something's off about it.
Yeah.
But,
so yeah, good. Yeah. So that's really good or insightful. A couple things. So one, I think there is a kind of openness. Like one of the perks, I think it's actually a feature, not a bug, of the view that it's really flexible in terms of what counts as good art. Because what we know is that people enjoy different art. They get things from different art. Maybe your thing is music, and other people are like, my thing is movies, right? So what aesthetic theory allows is, because it's subject-oriented, is to sort of make sense of that, sort of vindicates that finding. The other thing I want to mention is there's this analogy. So if you go back to hedonism, right, hedonism goes all the way back in ancient philosophy to Pythagoras, but sort of popularized by Bentham and Mill. And one of the key differences in hedonism is that there's some variance, right? So not all hedonists are alike. Some of them differ over what counts as pleasure, and maybe more importantly, what kinds of pleasures there are. So one of the key disputes between Bentham and Mill is over whether or not there are sort of tiers or kinds or qualities to pleasure. So you could have a kind of a pleasure is of a lower sort. Right? So okay, take that kind of a picture. If you think about the sort of aesthetic value realm, that kind of a thing is available for us. We could say that, look, there are types of aesthetic value, and there's aesthetic value in the Paw Patrol movie, right? But at the end of the day, like, no amount of that kind is going to overcome the kind of value you might be able to acquire from appreciating, from an educated position, the kind of art that you're talking about, right? So there is a kind of way to sort of understand the sort of popular level of aesthetic value, and still, give some credence to how important, some of the more technical stuff is. That's available to us. We don't have to go that way, right? Some people think that that kind of elitism is, or they're sort of frustrated by that, but I'm open to that.
Hi. Hi.
Hello.
I'd like to represent Paw Patrol.
Yeah.
Just kidding. No, actually, I was really, I enjoyed your piece, and I enjoyed the aesthetic value part. What I was wondering is, have you ever, when it relates to well-being, have you ever heard of a guy named Bo Lotto? He's a neuroscientist who actually did a study on the power of awe. So he would take an aesthetic experience, and he put a bunch of electrodes on people's heads, and he could actually chart the new experiences that they had, giving them a positive bioelectric, biographic or a biological response to all that stuff. And I just thought it would be an interesting comparison if that you could tie that into your aesthetic theories and all that stuff. But there's a real value to this, especially when it is tied to well-being and things like that. Opening up anyone's eyes to new experiences is a biologically sound thing to do. It opens up a lot of neural pathways and all that other stuff. So.
That's really cool. Yeah, I'm open to any empirical finding that there might be. So whatever the research says, that's what I think we should go with. That said, I am skeptical that we're going to get, sort of by way of empirical study, answers to all of these questions, paradigmatically philosophical questions, like where the aesthetic value is. Certainly, we're going to be able to find all sorts of interesting bridge connections. Sometimes people in philosophy might call these bridge laws, right, between mental states and neurological states. I think we're going to make tons of, we already have made tons of progress there. But I'm super interested in that kind of study. That'd be really cool.
I got time for 2 more questions.
I'm curious of sort of your, the line of thinking that got you to well-being. So, this is a lot to sort of try and summarize really quickly, and I apologize, but if our approach is to look at things from the aspect of well-being and what makes somebody's life, you know, are they doing well, are they doing good? You know, I think we run into this idea of, you know, like you talk about, you know, somebody being frustrated, even though their life, they're having all these things of good value that occur to them. But I can't help but think about the reality that the negative experiences that we have are what give us the perspective on what is good and well, right? That by knowing what is not enjoyable, we can define what is enjoyable. And, you know, when it comes to art, I'm going to relate this specifically to Circus. I can think of a lot of artists that, like, for them, the aesthetic value is just in the action of what they're passionate about, right? That they struggle, that, you know, they accomplish X, Y, Z, but then they want the next thing, right? They want to accomplish something else, right? We talk about like hedonism and right, like that. But they aren't, but they're driven, they're the sense of failure or I haven't gotten it yet is kind of what pushes them. Not the, I got the thing, right? It's, well, there's more to this thing. I remember talking to one who said, if I don't fail at least once a week, I start to get really jittery. You know, so he'd purposely seek out frustrating. You know, and on the other hand of things, that if we say has to be tied to well-being, then it's a question of the counterexamples of people that, you know, they seem to be living in how we would say well, but, or sorry, that are not living well, but those people believe they are. I'm thinking in a medical term. I remember sitting with a woman who she had been diagnosed 4 times with pancreatic cancer, been told she has 3 months to live 4 times. And she said, ever since that, the second diagnosis, she'd been living the best life she ever had. Because it was after that when she realized, not really on other people's definitions of what is well, that she could just do without having to worry about, you know, what is or isn't right for her to do. And it was only with that freedom that she felt she could find the aesthetic value in life. You know, she was one of the happiest patients I'd ever experienced. And, you know, living with one of the grimmest possible endings, stories. You know.
Yeah, I mean, so I think one of the things that's cool about the aesthetic theory is that it by pulling the value away from the object, the artwork as such, right, the paint on the canvas or the sound coming out of going particularly well, maybe there's lots of pain and suffering, but by her lights, right, by her own testimony.
I want to ask your opinion on that.
Yeah. These questions are really big and somewhat messy. So, and that's largely because terms like should are kind of messy themselves. So, one of the reasons some of these conversations are difficult to track is because we're isolating certain elements of what philosophers call normativity, right? So like, we're saying something's good, but like good in what way? In this conversation, we're thinking, well, good aesthetically, and then in well-being, like, you know, good subjectively, good for, right? And we haven't mentioned like moral goodness, right? Or all things considered goodness. So there's other dimensions to normativity or what you ought to do or what, you know, like what you should pursue or kinds of aesthetics you should like, right? So if we were really precise, we might ask questions like, is it morally good to increase in your aesthetic knowledge, right? Or is it aesthetically good, or is it all things considered? Okay, so that's why it's messy. I think all things considered, it is better for us because spill the beans, right? Like I kind of like the elitist view, right? When I, you know, in the example with the culinary arts, An example with the movies. When I come to sort of certain levels of understanding, I come to think that my prior understanding was not just different, but actually less mature, less developed, sort of made progress in my tastes in movies and my tastes in food. That's actually objectively good. Objectively good in what sense? Maybe not in aesthetic sense, but in all things considered sense. So I think there are actually more goods, and it's actually really sad if I can't achieve, there's so much beauty out there. There's lots of beauty that many of you are offering the world that I'm not in a position to acquire by the lights of my view, right? That's gonna take some growing and learning, and then hopefully I'll be able to really get all that there is to enjoy from it, right? But that's like a me problem, right? So I think it is good for me to grow. So I think the answer to your question is yes, but we gotta be careful about what we mean by should be.
Testing. I just wanted to make a quick little observation that possibly the funniest gap, or sorry, bridging gap in this whole thing is the fact that Cirque du Soleil owns Paw Patrol. So, yeah, fun fact, as of 2019. But also just an interesting observation, especially going with what Al was saying about measuring biofeedback and the sense of lead again. But then you can have that same novel experience again when you go and see that same song performed live in concert. And I think that especially with the acrobatic stuff that we do, or the musicianship aspect of it as well, because oftentimes in live shows the music is also live, there's a different experience seeing a clip on social media than actually physically being present. And I feel like there is a sort of element of social psychology in that. You're surrounded by all these people. You go to EDC and there's 500,000 people all just watching the same thing and having this collective experience. So there isn't really a question in this, but just sort of an interesting thought process on it. I'm curious how much novelty plays a part in this whole aesthetic well-being world.
Yeah. I don't know, I mean, you're right. I think that's super interesting.
All right, well, thank you, Isaiah. All right, up next we have my friend Kate Perlsweig. Kate has worked with special forces before, but she has probably had worse experiences having to deal with the likes of me. But Kate is currently in charge of performance medicine for all of Cirque du Soleil's resident shows here in Las Vegas. She was the head of PMed for Beatles Love when I was an artist there. Well, in my eyes, you were. And she went on to be the head of PMed for O, and now she's just running the whole thing. So, without further ado, Kate.
Thank you, everyone. So, there's going to be some familiar faces in this presentation today. Scott is here, Josh is here. We have a coach, Al Light, and then one of our strength coaches is represented here today too. So I am here representing myself. I'm not representing Cirque du Soleil. I want to talk about my experience in transitioning from traditional medicine into a circus and performing arts world, because that certainly wasn't my background. So parts of this presentation are something I've given at UNLV with the athletic training students, at other universities with athletic training students and PT students, about how we look at evaluation of things that we're unfamiliar with. So there's a couple parts I want to go through with this. The first is epidemiology. Let's look at the scope of what it is we're dealing with. Then evaluating the problem, evaluating the individuals, and some unique ways that we treat and manage these injuries long term. We do very much understand that circus and performing arts is not a pain-free experience for anyone, even if you are not injured. So how are we managing the difference between what's an injury and what's a normal pain or discomfort of performing the way that you do? So in general, male and female performers have really similar injury rates, types, and locations. All of these things seem to be much more related to the apparatus or the discipline that someone is doing and less related to gender. So if we look at traditional sport where we have soccer, the injuries in men's and women's soccer are more different than the injuries between a male and a female trampolinist or gymnast, okay? Acrobats do have slightly higher injury rates than non-acrobats. That does make sense, so in our shows, if a character is walking around on stage, that certainly carries less risk than someone on a trampoline, someone in straps, someone doing an aerial act. Overall, our injury rates in circus arts are lower than it is in NCAA gymnastics. So there's not a ton of published research on this, but the NCAA has 15.2 injuries per 1,000 exposures, whereas we're sitting at about 9.7 to 10 injuries per 1,000 exposures for performing artists, which includes acrobats. So when we look at this at Circ and how we're approaching this problem, so we define an injury as any musculoskeletal complaint that comes to PMed. There are 1 to 3 of us per show here in Vegas, so fully staffed, we're 16 therapists. Here in the US, we're mostly credentialed as athletic trainers. We do also have physical therapists that work with us. Circ is an international company, though. We do touring shows. So we do represent a wide variety of disciplines, Australian sports physios, we have Canadian athletic therapists, from the UK we have physios as well, so it's a really diverse group of people and approaches. Something that we don't do well is looking at acute versus chronic injury types. So here in the US and in Clark County, Nevada, we're a business, we are employing artists. That means that every injury is a work comp injury. So in order for something to qualify as a work comp injury, it has to be reported as an acute injury. I fell off of something, I stubbed my toe, I stood up and this hurt. Rather than I've been performing and dancing on the stage for 20 years and now my feet hurt every single day when I get up. So when we look at the categories of injuries that are reported to us, almost everything is acute, and that's strictly in nature of how injuries are paid for in the American healthcare system. It's not necessarily an accurate epidemiological picture. So our injury rate coming out of the pandemic, just before the pandemic, was 2.02 injuries per artist per 1,000 shows. And that in 2018 represented just over 1,000 time loss injuries in 2018, and that was at all RSD shows. For us, that wasn't necessarily a useful way to explain to the business that we work for how impactful these injuries and time loss things are. Because if I'm on a team and someone on my team is out, that means I'm working harder to be able to complete this act or complete whatever it is that needs to happen. So we started using injury burden. This is not a rate. This represents the percentage of cast that is not available each day due to injury. So right now, this is sitting at about 5.5% across RSC shows. So we've got 6 shows going in Vegas plus Stronger Life in Orlando, and right now today, 5.51% of our cast is unavailable because they're injured. So some of those are short-term things, maybe about a day. Some of those are long-term things where hey, I've been out for 9 months because I had a surgery. We also keep track of personal health conditions. So if you were injured in a car accident or you're unable to perform because you just had a baby, we call those personal health conditions. We still keep track of them, we still treat them. For us, that burden is a little bit lower. It's about 3.4% today across our resident shows. When we're looking at what injuries are across Circ, so like I said, almost everything is reported to us as an acute injury because that means it's a work comp injury. Very rarely is someone going to come in and say, yeah, this has just been getting worse over time and I would like to pay for it on my own. So most of ours are reported as either contact or non-contact type injuries, and we have 11% about that are gradual onset. There's insurance issues with saying gradual onset. That doesn't mean it's never accepted as a claim. So we do capture a very small amount of those things. And then injury type, just like in most sports medicine research, we see mostly sprains or joint injuries, strains or muscle injuries, and contusions. So very, very similar to what we see in general sports research. Then looking at injuries by location, our most common injury locations are low back, ankle, knee, shoulder, neck, and that is exactly the same as most major sports medicine research. And that really doesn't matter by sport. You know, those are the major joints of the body that when you get out of bed, they do hurt. So then looking at this at a show level, you'll notice most of these pictures are Love and O because that's where I've worked. This data from 2019 is not either one of those shows. We picked a median number. So for the 3 performance medicine therapists at the show, we performed 4,649 interventions in that year. 3,000 of those were for work-related injuries, 722 were for personal health conditions, and about 1,500 were preventive interventions. So that means you came in to see me to say, hey, this has been getting kind of sore, can we do some exercises, can we do something like this, and not, I don't want to open work comp claim, but I do need some sort of attention. Then defining that further, looking at the major locations of injuries. So looking at a full cast of 65 people, acrobats are the people that are doing tumbling and flipping, airlists are doing climbing and hanging, dancers are dancing, and our characters or clowns are non-acrobatic. They're generally, we consider them more of an endurance position where they're doing a lot of standing, walking, running, they may participate in some choreography, they spend a lot of time on stage. So our most common general injury locations for these people are pretty consistent. So obviously acrobats are doing a lot of landing on things. They most commonly injure their lower extremities. Our aerialists have a lot of back injuries, and then surprisingly also have a lot of lower extremity injuries. And part of that was because of the track system that we use. So you may do your aerial act, but then we also need you to run around on stage and do this choreography. And if I take you as an aerialist and I train you to dance and I train you to do these things, you're going to roll your ankle and you will see me eventually. So in this period of time, so this was 2019 as well, these artists completed, each individual artist completed about 94% of their total possible shows. So in general, our performers are doing between 470 and 480 shows a year. That's 10 shows a week, 5 days a week for 48 weeks a year. So there's 2 one-week breaks and 1 2-week break. So, knowing all of that, how do we approach our injury evaluation? So, just like any subjective history that we take when someone comes to us with an injury, there's external factors and internal factors that may have contributed to someone getting injured. Something unique for us is wardrobe. There's a lot of layers to costume. Maybe something that's not fit specifically for you. Maybe it's something that's shared between several people because it's this giant thing that goes over your harnesses and over other stuff. It may be something that is specific to you, but it has a weight to it. It changes your center of mass. It doesn't make you unstable. Is the thing itself unstable? How many layers of it? So this is one of the opening acts at Love, and there are several different bungee things happening here. So Josh is wearing a front pick harness. She has a partner in this that is wearing a back pick harness. They're connected to a line that is going to move at 6 feet per second out of the basement. So there's a bungee pack between the 2 artists that is connected to the line. It's not connected between the 2 artists. So they're lifted out of the basement. Josh can demonstrate. And confetti cannons really do help everything. So this is a bungee act, and when a male performer comes in and says he was injured during a bungee act, well, he's not connected to the bungee at all. He has a flyer that's connected to the bungee, and that line goes behind his head. But you can see, too, how his center of mass changes because of that back pick. And we also have here bungee straps artists. That same thing are pulled from the stage up, and that's a winch movement, and then there's usually someone on the ground, like our wonderful coach Ault, that's holding them down to slingshot them up. So this one, Nate's gonna have to do it for me every time. So this is Kat Donahue. She was an athletic trainer with us, and so on her last day, we decided to let her do bungee jump. She's completely fine. Sorry, to preface that, she's completely fine. So she's an athletic trainer that worked with us. This was one of her last couple days at work. She is a doctor now. So this shows the importance of core control and how flexibility plays a role in what people are able to do and what they may be injured doing. Because Kat's someone that's really strong. She was a Division I athlete. She's a smart person. And then we said, okay, you're going to hold this hollow position, and then we dropped her, and you can see how well that went. But again, she's completely fine. So another thing that happens with us a lot is people come in and say, I was injured doing a rope climb. That means so many different things. So there's so many different types of ropes. There are so many different types of climbing styles. They're used for acts. They're also used to access places. So if I have a power failure and I'm in an aerial act, very often I have to climb down a rope or up a rope to get to a safe position and out of my apparatus. So when we're evaluating an injury and someone says I was either injured on a rope climb or no, I'm definitely okay to go on the show, I'm in a harness, it's cool, don't worry about it. It's like, well, if there's some sort of failure of equipment, can you climb up or down a rope to be able to rescue yourself? What is the rescue plan for this apparatus? There's also some really wild climbing styles. So these are gopis. This is not you. These are gopis that love. And they really do a toe climb for this. And the rope itself is a much narrower diameter, which means you have to have a much higher grip strength to be able to climb and to pull yourself up. This is also a really good one about where your calluses are and how you're maintaining your skin and where you're getting cracks in your skin and how you're maintaining that for yourselves. It's one of the most important things that we deal with, because if you get a crack between your toes where your callus was from your rope climb, I mean, you could maybe not be able to do that for 4 to 6 weeks while that actually heals. So Joel Bean and Bernadette Buckley are two people that do a lot of research in skin management and callus control and stuff, and they're really great authors. So if you're looking for something else to read on that, they're wonderful. This is another type of rope climb. So this is a Korean rope, and he is climbing because there's a porter under him holding tension down. So this is very shortly after. This is a dancer that was learning this. So each time he's pulling his leg up, the porter's releasing tension on that line, and then to be able to slide down, the porter's releasing tension. So if that porter below him changes the tension or he slips, that's where we run into problems here. So this is, you can see how he's trained, it's gone better. So, but that person below him has to be very consistent with the amount of tension that they're applying so that he can effectively climb. Stilts, another surf thing. So there are so many heights, materials, and coverings for these things. In general, these connect like right around the tibial tuberosity, so it's just below the knee. And then there's parts that connect over feet. So depending on how tall these things are, depending on how much weight is pulling on the knee joint. So it's a distraction, it's opening at your knee joint. So for someone who has had knee surgery, has a chronic knee instability, has a hip issue, these are major issues that we need to talk about. Someone have in developing their skills, in being coached in their skills, understanding the difference between pain and injury, and being able to communicate about their physical status, that plays a huge part in our ability to assess their injuries. Same thing for training age. So this is something that's we talk about in the strength and conditioning community a lot. So how much experience does someone have at doing this discrete skill? So does someone know how to deadlift? Do they know how to squat? How many years of experience do they have at those things? And then we do 480 shows a year, so just in general, how tired are you? And then this one, I think. So this one, I think we'll see some familiar faces here. So this is a UNLV lab, and Matt is interested in learning more about himself. So his data from this isn't necessarily useful for anything other than it looks really cool. But it's not really generalizable to a different population. But this is what we took out of this. So we didn't look at any kinematic data because it was impossible to keep the marker systems organized. We did look at kinetic data. So lower body, basically these are jump landings from a front flip, 2.2 times body weight takeoff, 11 times on landing, back flip 2.9 times on takeoff, and 12 times on landing. And then a lot of that one arm stuff, which does make this guy incredibly unique. His single arm strength is wild. So those one arm hops that he was doing, he did like 50 of them in this video, 3.6 times his body weight on that arm each time. The air flare is 2.5 times body weight, and then the air chair, where he's going from his hand to his head on the ground, it's 1.9 times his body weight on his hand and 3.6 on his head. So information like this, while it's not really generalizable, does give us some context to what it is that he's doing to himself every day. So really interesting. We can compare this to stuff like heading a soccer ball, which is about like that, except for this is a steel stage, so if he slips, there's a slightly more risk for him than there is for, you know, getting your nose broken on a soccer ball. So for the head stuff, it's basically heading a soccer ball going 50 to 60 miles an hour for this data. So that's some unique evaluation stuff. Some treatment things that we do. Blood flow restriction training is something that I think is really cool. And this is something that it's a little bit more mainstream now, but it started really in Japan, came through Hawaii. It's called Katsu there. And this describes exercising with partially restricted arterial inflow and fully restricted venous outflow. So what this does is it takes what would be a normal exercise and forces it into an anaerobic metabolism. And so that changes the chemical properties of what's happening in your muscle. So it increases lactate, it increases muscle fiber and motor unit recruitment. It makes it feel like you are doing maximal exercise. And your body reacts as if you were doing maximal exercise, but really you're maybe just doing squats with your body weight. So with traditional weight training, it takes us, you know, more than 70% of a 1 rep max, doing reps with that to be able to get bigger muscles. Blood flow restriction with low loads can get you bigger muscles and can get you stronger with using almost no weight. So the effect size for a strength gain with blood flow restriction is pretty massive, and it's almost zero if we use no blood flow restriction. So as with everything, there are contraindications to this, and those are mostly cellular in structure and nature. So cancers, DVT, clotting disorders, for those things, as usual, we would not want to mess with your circulatory system. These are the prescription guidelines that we use. So we use a system called the Delphi through Owen's Recovery Science. There's one at each show. So in general, this is something that we're trying to do 2 or 3 times a week over a 10-week period. We do 75 reps of a single exercise for this. So the first 30 are to create that anaerobic environment in the muscle. And the second 3 are to actually do the exercises in that anaerobic environment. And again, it's low load, so we're using no resistance, or 20 to 40% of your 1 rep max. We're doing them slow and controlled, so 1 to 2 seconds each. We're giving you 30 seconds of rest between, which feels terrible. Like it's uncomfortable. And for a total time of 5 to 10 minutes per exercise. There's a ton of research on this that has looked at the width of the cuff that you're using, how much occlusion are you using, and it's pretty clear consensus that at the upper extremity we want to use 50% occlusion, and at the lower extremity we want to use the EV. So can I do something that isn't terribly physically taxing and then make my muscle? So this increases muscle perfusion, the oxidative capacity of the muscle, have a local method needling or a couple different parameters, and these are a deeper treatment and longer needles that can last more than 3 months. So needle diameter, obviously smaller needle is going to be more comfortable. However, if we're targeting a deep tissue, we may need to use a larger needle diameter to make the needle stiff enough to actually reach what we want it to. Intensity of this is defined by the number of needles we use, if we're manipulating those needles once they're in situ, if we're adding stim, and then a duration for these, usually between 5 and 30 minutes. Anything above 12 minutes is where we get our peak opioid response. And then treatment timing depends on patient tolerance. So this is something that can relax people a lot, so it may make them too sleepy to perform afterwards. It may be something that makes someone very sore, so we wouldn't want to do it before a show, maybe we do it after. And then for some people, it has no immediate effect that's going to affect their performance, other than this makes me feel better, please do it right now. Our last thing, conditioning. So in order to do this job, you do have to be durable. So we try and approach that as a team. So that's me in performance medicine, that is Jade as a strength coach, that is Al as a show coach. We also have a dietitian and sports psych that we consult with. And knowing that with all of these things, we do have to be really mindful of all of the demands that are placed on this person. So I'm tired, I'm sore from shows yesterday, it's getting to be near the 2-week dark, so I just cannot take any more. That means that we're probably not progressing in strength and conditioning for, you know, we're not getting that 1 rep max for our deadlift that day, but that doesn't mean that is something that's less important. That does mean for our conditioning training programs, unlike sport, we're not driving towards a competitive season, so we have to make this kind of fake macro, meso, and micro cycle for people when we're talking about helping them become more durable. So these are based on what someone wants to do. It may be formatted around a dark, it may be, hey, I'm really working towards this goal, and we'll work with them to do that. So, what questions can you answer?
Do people with a hypermobile disorder have a higher rate of injuries?
No. So, in general, people that are hypermobile, first we love to hire them. But at CERC, by the time we get someone, they've been hypermobile their entire lives, so they're pretty self-limiting about, I can do this, I can't do that, or we've just put you in a contortion act and we know we're not going to bounce that person off the trampoline.
Thank you very much for your talk. A couple questions. First, being with regards to blood flow restriction. The main purpose, obviously, there in replacement of traditional strength and conditioning is to reduce that joint load. Is there a reason that the parameters indicate that we stay around 2-3 times a week when sometimes we would be doing 4 or 5 times a week strength and conditioning training? Traditionally, is there another effect that we have to watch out for, because we're obviously not too worried about the soreness or the joint load? So curious about that. And then second question would be more just pertaining to the durability that you mentioned for our aerialists, anyone hanging by their arms. Is there anything that you've noticed? We actually had mentioned in an earlier presentation the difference between that and a baseball shoulder. Anything you found to be particularly effective for the shoulders, so that and the BFR.
Okay. So BFR, my approach in general is minimal dosing response. So if Scott is coming in and I know he has shows 5 days a week and he's doing all this other stuff on his own time because he has hobbies, I don't want to prescribe Scott to do something. We're going to do this 7 days a week for X number of weeks, because I don't want to he doesn't need to overload his system. BFR isn't a replacement for traditional strength and conditioning. So on days we're not doing BFR, it's very possible we're doing something else. Because as you guys know, in this environment and in any sport environment, there's no replacement for doing the thing that you actually do. So if your job involves manipulating something that is heavy and awkward, you have to be able to hold and manipulate something that is heavy and awkward. So with BFR, chances are we're not replicating that, but we are getting a muscle hypertrophy that is necessary to be able to do the heavy and awkward thing. So a lot of that is more like a strength and conditioning theory approach. So the way that we do it, or the way that I do it, may not be the way that you do it. But in general, my approach for that stuff is minimal dosing response. I want to do as little as possible to get as big an effect as I can. And then shoulders. What was the question? How does it?
Bit selfish, but the main point is when we're dealing with overhead athletes that are not throwing, they're hanging, they're suspending, they're launching themselves from these apparatuses at times. Is there a difference that you found or anything specific that you utilize that has proved to be like Pareto principle, the 20% that keeps the shoulders 80% healthier?
I don't have any shoulder magic. We do a lot of dynamic stabilization stuff, so we use some like gyroscope kind of things, or dynamic stabilization. There's I'm blanking on his name right now, but there's a shoulder device that is really popular in baseball, because we do end up using a lot of baseball stuff. Like pitchers are expensive and they're well researched, so devices that are developed for them to strengthen their shoulders have been really effective for us. So like the body blade, anything that requires someone to stabilize has been effective. But no, I can't say we have solved the shoulder problem.
And then I have a question, just because we bring up blood flow restriction, and we brought up the big DVT word, which is the giant boogeyman of emergency medicine. Is it only history of DVT that precludes them, or would you not, in emergency medicine, we look at like risk factors of DVT, PERC positive, or someone has high risk?
For that, we have plenty of women that are taking birth control, or we have a lot of heavy smokers and not eating, or all of those things that are huge risks. The way we describe this to our physicians when we're asking for approval of this, because it's weird to say, hey, I want them to do exercise with a tourniquet on. What we're asking is it safe for this person to undergo surgery? Because if you can have an orthopedic surgery and have a limb occlusion for 2 to 4 hours, then you are safe to do 10 minutes of an exercise. So when we're asking medical clearance, that's the question we're asking.
So when you showed the numbers for the B-boy, you talked about kinetics and kinematics. Can you just tell me the difference between the two of them?
Sorry, kinetics is force plate, kinematics is motion. So all of those markers like that you would see for like Avatar and that motion capture stuff, those markers are showing joint angle joints. Kinetics is at the force plate, so his interaction with the ground. So either pushing off of it or landing on it.
So when you were measuring all the numbers, when he was doing the different movements, saying it was X amount of times the body weight, that would be kinetics, right?
Yeah, that's kinetics.
So what's the issue with the kinematics? Is it just too many vectors to calculate at one time?
Completely. He's spinning so fast, markers are flying off, and even though that system has come so far, and even like there's really interesting stuff from the Avatar movie and how they developed underwater motion capture from that, and the computing technology and AI that went into that. Even with that, we can't estimate that quickly at those joint markers. So what happens when he's spinning? The computer and the 10 cameras that are around him seeing that, they're losing track of what it is. So then frame by frame, someone can go in and say, no, that's still a shoulder, that's still a shoulder, but we're not getting any usable information from that. So committing the 40 hours it would take a single person to identify the marker every time isn't worth the time.
We got time for one more question.
Okay, in regards to blood flow restriction, I love it, especially for my post-op patients and stuff. I've had some therapists tell me they won't start until 6 weeks afterwards. And you mentioned in one of the slides that one of the things is like an open wound or something like that. Is there, or 2 weeks, I would think that blood flow restriction would help actually in wound healing. Do you know if there's any data on that? And
so, yes, so there is. And depending on the physician will depend on how conservative they are about when we can start. So the version of this that we use is developed by Johnny Owens, and Johnny Owens is a PT that was affiliated with the Army for a really long time. So most of his stuff comes from Center of Intrepid. So when we did blood flow restriction there, you are doing BFR with someone who might have an external fixator, who may have very complex wound situations, and coming out of all of that data, the only thing that he really found was that if you have a complex hand or foot injury, like a very fine motor sort of thing, that's where the BFR was not helpful and could actually hurt outcomes. But otherwise, for wounds and stuff, in general, we'll kind of wait about 2 weeks and then, no. So if you wanted someone to do it sooner, I think that you could say you wanted them to do it sooner.
Okie dokie, we're going to switch out laptops. Perfect. So I'm going to introduce our last speaker of this section. Dr. Ault is an emergency physician. With me, he is my mentor at UMC. He has worked so much with my friends that are acrobats, the people at Circus Center, myself, of just coming in and being like, I have this weird thing in my wrist, please help me. I have this shoulder pain from trapeze, please help me. And he has been very interested in discovering not only all the things that we can do in traditional medicine, where do you go to get the x-ray, where do you go to do physical therapy, but all the other things that we can do for our athletes, both elite athletes and recreational. So please help me welcome Dr. Ault talking about our non-conventional medical treatments.
Everybody hear me? Okay. I put all the rest of those things on because I do have a tendency to walk around and to say things and move around. So hopefully you can hear me and we'll keep going. Here. I did. Do you want this up higher? Here we go. Are we capturing better? Okay. So my name is Brian Ault. I'm a full-time emergency physician, but that's a plus. And we'll get into that. My first is a thank you, and a thank you, and a thank you, and a thank you to all of the Circus members who are here, who are watching, who are in the community, and who, at the very least right now, have lent me their talents, but also those that I've got me to work with and for. And I'm grateful for that. You're an amazing group of people. And I can't tell you how special you are. So I have no financial obligation or disclosures, and we'll get going. So, this is part of my problem, ultimately. So conventional medicine. Conventional medicine is basically I give you stuff, I shoot pictures of stuff, and I cut stuff out, more or less. That is what we are trained to do in allopathic medicine. It really doesn't work all that well, unless it does. There are some things that work very well. But I think it's an incomplete view. And so this is another thought. It's a really interesting thing. It's the African Journal of Traditional Complementary Medicine. But I really like the description. So traditional medicine refers to health practices, approaches, and knowledge and beliefs incorporating plant, animal, mineral-based, spiritual therapies, manual therapies, exercise, applied singularly or combined to treat disease and illness. So what does this do? This is complementary and alternative medicine. This is the combination of all things we do. Unfortunately, this is only one side of the two. So I'm going to say, we have one side that's conventional medicine, we're going to have another side that's traditional medicine, and how do we blur the lines? How do we do this all together? And we do this when we work out. We do all kinds of different modalities. We've talked about blood flow, we've talked about all kinds of crazy things, and that's okay. And then in medicine, we do this too. When we treat anaphylaxis, we give you multiple different medications and hope they all work together to kind of work together to get you better-ish. So I'm going to challenge you with coordinated care. This is purposefully busy. This is absolutely purposefully busy. This is kind of my way of doing medicine. It's probably not the norm, but I think it's different in a good way. And what this means is depending on what you need or need, supplementation, whether that's even simple things like probiotics or fish oils, or other herbal medicines, are you using osteopathy? I'm an osteopath. I use traditional osteopathic manipulation. This is how do we connect structure and function to allow you to function better. I love that. We talked about dry needling. How do you do dry needling? What is your preferred method? Do we do nerve blocks as well? I do trigger points in dry needling. Depends on your day, your case, who you are. It's interesting, everything you say, I was kind of laughing because it's all things that we've tried, the superficial, the deep, how you have patterns. There's a million different ways to do this, and some work great for some people. I am not one of those fans that likes these patterns of lots of superficial ones. It just doesn't sit well with me. But that's me and my body. How do we use modern medicine when it's applicable? Or do we use it for years and still is here? This person needs to go to the OR. They got a gallstone. I can't fix that. This person has a heart attack. They have occlusion there, and we need to sort that out. And this guy shot himself in the foot. Actually, his grandmother shot himself in the foot. Shot him in the foot. Like a box to think about how we can affect different conditions. And then, who am I? So, to how do you manage his stresses? To our performers who are a unique skill set of amazingness that don't do normal things, what we consider normal. And health in the big picture is a continuum. But what you'll notice in the center is it's a road that's often unpaved and rocky. It's not as clear cut as left and right. And bigger yet, the body is more of the products of the whole. So if I just tell you this is how everything was made, that's fine. But I can't give you flour, water, and salt and say make it bread. So we can't treat the body that way too. And unfortunately, with modern medicine, we have this beautiful, wonderful way of creating silos. What I mean by that is it's just easy from a liability perspective, from a specialty perspective, from a training perspective. I'm going to let you see each one of these pieces. So, I'm not going to put his picture up there, but there's a good friend of mine. Okay? Cabbage, which coronary artery bypass, we put grafts and plug in and circumvent bad blood vessels. You break a bone, we put plates in. Infection, we give you antibiotics. Transplant, we give you all kinds of drugs. I hope they work. But at the end of the day, if your body doesn't help you, why did you get in the car accident today? Why did you fall down yesterday? Why did you ride your bike, which you've ridden 1,000 times, and today you hit a rock and fell down? I don't know. Bad luck. People say, why did I get a heart attack? Bad luck. Because why yesterday was I fine, and why in 20 years will I be fine, but why was today? Some things we just don't know. But what we can do, what often leads to this, is how is our food? What do we eat? Are we on the fast food diet? We're going to eat everything at McDonald's and see what happens? No. What about our sleep? So the beautiful part of performers is you often are at night. Great. How well did you sleep when you came home? You got home at 2, maybe 8, maybe you drank, maybe you didn't, and now it's like 3, 4, 5, 6 by the time everything gets going. And then you try to sleep in a somewhat dark room with off hours and now everything. And people will tell you, as a guy who does too many night shifts, oh, I got this. I can sleep. I can figure this out. You don't got this. We're not right. The sleep is a problem. And what about the physical, mental, relationship, and financial stresses that weigh on us? What about the extra things we do on the side to make this work? Whether it's for fun, or hobbies, or playing a role in our life. What happens as performers? We slip, we fall, we bad catch. Or equipment, you mentioned trains that don't work, or you don't like them, or they need service, or there's a problem with them, or the floor is harder than we'd like. And then we have this whole fear of failure, which is really interesting up here because everybody sees this. This is Instagram perfect. We and Facebook and Instagram are beautiful. And then there's a whole bunch of stuff that got takes that nobody sees. The most interesting part about this slide is there's only one thing on that picture that is hard work. It's the physical activity. You do your thing. But the persistence, the failure, the sacrifice, the habits, the dedication, all of these things are part of the whole that we often do. And in the big picture, it's all connected. So, short-term stresses in life, in general, increase energy, increase cardiovascular output. Long-term stresses, really bad. Poor overall life performance, decrease immune function, abnormal digestion, suppressed reproduction, anxiety and depression. That sounds great, wonderful, that's what we all want. So I go to work tomorrow, yesterday, Thursday, and it's a busy day. And so I see a lot of patients. And now, oh shoot, one of my residents is sick and doesn't feel good, so she's, one of our docs doesn't feel good, he's out. So now we have increased workload. We have increased pressure to see more patients. And now I gotta sit and interact with this darn computer more than I ever want to. And then my I'm getting headaches. Did I eat? What? Did I grab something out of my bag, or did I eat good food? Did I drink? Did I pee? I don't know. So now I have a headache, my vision's getting, my headache getting worse, I'm getting hungry and fatigued. Now I get in a fight with the nurse that I really like, and I get in a fight with the patient who really just walked into the day. And then best of all, I slipped on a puddle of the drunk guy's pee. You all laugh, but there are puddles of drunk guy's pee. It happens. And now I'm hurt. Was it me? Was it that day? Or was it the entire thing we just talked about for the last several minutes? Beautiful zebra. So zebras are a picture of episodic stress. They run around, they eat, they sleep. Lion comes, they run. They go away. Now they're calm again. There was an interesting study in 1994. It's out of the Netherlands. The thought was, if you take calves away from their mother, i.e. to raise veal, and to keep mom making milk, what happens to these calves? And why were these calves getting stressed? they were seemingly having physiological and psychological problems, and then they were developing ulcers. So, so it's not unreasonable to think that if calves, another mammal, are exposed to sustained, persistent stress from the time you are born, that is not episodic, that we're not physiologically meant to deal with, why wouldn't we have the same response? So my goal for all of you and in life is coordinated multimodal care that focuses on specific performers' needs for optimal mind, body, spirit performance. Sounds so easy. Nothing about these acts are easy. They're difficult, uncomfortable, stressful, dangerous, high risk, but not out of control. They're done purposefully and beautifully. But we have to, in the big picture, think about what is normal and what we expect to be normal. As we talked about all day today, there are a lot of things that we see and do and that we appreciate that are the norm. For our performers, this is the norm. If I take this away, they're not whole anymore. So how do we keep an open mind? These are tremendous athletes. Ironman triathlete, powerlifter, world champion powerlifter. The beauty with them is they can go home. And what I mean by that is they don't have to have 100% commitment all the time. If they are in the middle of a race and they hurt, it's only quasi-true because there was a friend from college who was a professional triathlete. She finished her run and then broke her hip. She ran until she really couldn't run anymore and then crawled and then they took her off the course. That being said, she still left the course fully intact. We talked about our military medicine colleagues downrange. You can't say, I want to go home. Bullets are flying and I'm done. No, thank you. It doesn't work that way. Just like mid-act, I pulled my rib. That's what we heard earlier. I had a significant alteration in my physiology and now I'm stuck 20, 30, 40, 50, 60 feet up in the air. What do I do? So what makes elite athletes exceptional? There's an expectation of pain, expectation of suffering, the difficulty that they went through, and we talked about fails earlier. I have to fail her unless I'm not whole. Again and again and again and again and again, because that's what keeps me honest. The unwavering dedication of task despite potential risks and harm. Belief in the self and ability, which means no matter what the outcome, we are going to succeed. How much they're willing to tolerate. We talked about earlier with athletes, well, why can't we do 4 days a week? Well, because this guy over here went and spent 12 hours in the gym in addition to showing up for his session. Because that's what feeds the soul. And the feeling of wanting more, the feeling of digging deep. And this is what is the capacity for challenge. This is a fundamental property that's different. It's take the attack and attack and attack. I use the example of Tour de France athletes. You have now been riding for 100 miles and you have to attack to the end. Again and again and again. The whole part of the team is to bring a team that attacks the lead rider again and again and again, trying to break them. And this is ultimately what happens when you're performing. Anyone know who this is? Right? Michael Phelps, one of the most award-winning or most medal winners in all of the Olympics, let alone swimming. So he talks about in 2008, he had won 7 medals. He was going for his 8th, and he gets up there, he starts his race. He dives in like he always has. He has all of his gear, everything goes wrong, and then everything goes lights out. Within 25 meters of his race, he cannot see. His goggles had come off, they had filled up with water at some level, and now he is stuck. So what do? What does he do? He says, I quit. I'm done. He was physically and mentally prepared for adversity and challenge. He reached out and said, well, I know how many strokes it is between every segment of the race. I know how every 50 meters, I know how many strokes it takes. I know how many breaths it takes. I know where I am in the pool, left and right, because I see people around me. I can finish this race. So he does. He sees he doesn't see for 3/4 of his race, and he wins the race. So what happens if it's me? And I'm not the extraordinary. So I'm skiing with Dr. Giles. Dr. Giles, we see a beautiful spot, one of my favorite spots in Park City. We see a beautiful spot, we go down this run, and then all of a sudden, he falls down. He hurts his shoulder. He can't get back up. We have to call ski patrol, we get him in a toboggan, and we take him down. He goes down to the clinic, he gets an x-ray, says, yeah, you broke your shoulder, here's your sling, have a nice time. What does that do? What do we do next? So he goes back home, he gets an orthopedic consult, says, yes, your shoulder's broken, we're gonna need surgery. But he's a physician. There's a way he can work in the front, he can work in the triage position, he can be the front from the beginning, and it stinks. But he can use his brain, he can use his other hand, he can vacuum, he can do what he needs to do. So if he were a handout, and now he's like 3-4 weeks out, then he's been splinted for a while, said, okay, great, you need surgery. Okay, great, fine, that's like care. And then 6 months later, he's back. What happens if your whole livelihood as the principal trumpeter at the Capitol Theater, he knew that every time that they filled the pit, he needed to be the last guy in. He needed to be the last guy in because where he had to stand was right by this big swinging door. And he knew for years he did not want to be the guy who got hit. So he warmed up in the hallway, he always was out there, he waited till everybody was ready, peeked his head out, got everything ready, he got up on stage. So on this unfortunate night, he gets up on stage. He thinks everybody's in. Fortunately, the bass player was late. The bass player goes swinging that door open, it smacks his horn, breaks his horn, busts his lip. Splits his embouchure in half. So he manages to still play the entire show that night in typical performer fashion. He has blood all over him, but he finishes the show. He then continues to play for the next year because getting care wasn't just something he was going to do. They didn't understand. They weren't going to make it happen. How is he going to make this work? So he now is to the point where he can no longer hit the upper registers that he was known for. He is having difficulty playing gigs. He figures out ways around it. Until when he finally had to stop playing, he would take a drill bit into the hole of the wound before he would play to express out the pus, play his gig, and then continue on. Unfortunately, after a year of this, and he was getting pretty rough, he went back to Mexico. He was with his family. They sorted out how to get him the care he needed. A year later, he was able to return. Amazingly, he was able to return to not only his current success, but his improved success to the point where he toured until he was 69 years old, playing his principal. So what have we learned? And I'm grateful for Nate for all of this because, and the work that all of you have put in, but unfortunately there's a culture of working injured, hiding injuries. We have some sort of care, but what kind of care does that actually mean? Is it just catastrophic care? What can we actually get with that money? And then I understand why there isn't necessarily the confidence. Conventional medicine sucks. This is not worth it it is not worth often going when you know your body better than anyone else. What are you going to tell me it's not broken? Yes, I can walk on my hands, I can stand on my leg, but that doesn't fix anything. And then most people won't understand. They won't get it. And then how do we have the time? What if I'm in between shows? What if I've seen PMed, I've worked at and I don't have a chance to get another opinion? I'm having trouble, it's not getting better, what do I do? Oh, yeah. Well, Nate, and what if I have a partner? What do we do if I'm part of a 3, 5, 6, 8, 10 member team and I don't get them? Now we're all out of work, we're all out of time, we're out of job. I attribute all of our lead athletes and our performers to feral cats. Nobody wants to sit still. There's a reason why we do things again and again and play, but there's always more time. I have more time in my day. What else can I plug into that hole? So how do we work to change these things? So when we look at injury and rehab, we have to know what that performer does because it makes a difference. And how were they injured? Were they training? Were they on their own time? Was there something different? What part of their apparatus catch them? Was it some part of their harness? How do we work within the confines of what they do? And then how do you train? The importance of how you train is just as important as what you do for a living. Because sometimes those training pieces are part of the problem. Or the training piece is the only thing that keeps you sane and healthy. And then how much time you have. We talked about this, but what if you can get free? But what does that look like on a real granular level? How many shows do you have? When your day is off? When are the practitioners available? When are they not? How can I get into therapy? How can I get into an MRI? Am I going on tour? Am I off tour? Where is this going to play a role? And then can we work around an injury? But this is an asterisk, because it's often, can we do that safely? Because what we don't want is somebody else getting hurt, themselves or other. Or is this need some sort of compromise? And okay, fine, we get you kind of better, but how do we change our mindset so that you don't repeatedly get this injury? Do you just need time to heal? Can we modify a position in apparatus or an act? And then the real consideration on the back end is, okay, what's the true financial implication? I know that we said 78% had insurance. What does that cover? What's that worth? There's a lot of other things that we spend our money on to keep ourselves running. But what happens if it's just not enough? What if it's too much for us to manage? And the social concerns. For a lot of folks, the livelihood is not simply in the act that they perform for the money, but it's their friends, it's their relationships, it's their social outlet, it's their supportive network. What happens if you're hurt and take those away? Go hang out in the corner. We'll call you later. The mental and physical implications of these things are huge. So we talked about additional treatments, we talked about additional treatment risks, we think about alternative treatment risks. And I'm going to tell you, in my mind, these are really small. The way I do these things, this is, your risk is low, your cost is low. I start with osteopathic midfield treatment, and that's part of my soul. But there's a lot of pieces of this puzzle. And that's okay, that's the good part. And I'm going to give you an example of alternative preventative medicine here, is that I would not be an emergency physician to tell you that I do believe in vaccines. There was a time when I would have told you that I was an anti-vaxxer, and I said, you know what, there's herd immunity, it's okay. I think we'll be okay. I joke with my wife and I joke about how with our kids, they get everything. They get every vaccine. Because I know about things when people were really sick 2 to 3 weeks later. Oh, you came in contact with X, Y, and Z. How was your dengue fever today? So when they come stick you, everybody goes, here you go, here's your arm. If Scott's going to go stand on his hands today, tomorrow, the next day, how good's he going to feel when his arm hurts like that? My arm hurts and I can't lift my arm. Call me. But what if you're standing on your hand? What if that's your livelihood? But are we okay with alternatives? There's lots of big muscles. I got big ones in my butt. I got big ones in my thigh. How about we work around what you do? Okay. Oh, Mike. Let's see this question. There we go. Okay. So we're going to talk about some coordinated care examples here for a minute. So my favorite lacrosse player goes and scores a game-winning goal, comes hobbling off the field. She's busted, can't figure out why, ankle's all swollen, somebody tripped her on the way. And now it's ugly. Now what? Here's your crutches, have a nice day. Call you later. Can we do better? Do we just do NSAIDs, mobilization, rest? Well, sure, I guess. But what if we looked at this and said, okay, is there anything I can do for ligamentous growth and healing? Can I decrease traumatic inflammation? Can I balance the tissues and create better structure and function? Can I increase lymphatic flow? Can we talk about how we can do some graded activity if it works? In terms of what kind of activity can we get her to do? Is it just moving her ankle a little bit to try to allow this to move while we're healing? Are we looking at functional bracing? Are we looking at how, in our performers, how does this work with costumes? What else can we do? Can we do cold laser? Do we then think about as she gets better, what kind of footwear will she wear? Do we need multiple different surfaces, different shoes for different surfaces? And in some cases, how does an orthotic help? In things where you have fixed, flat bottom shoes that are really stiff, an orthotic that gives you better control and better marrying with your foot and that floor, how can it help? So we use osteopathy. We give you practice for doing other things when you're not able to do things with your ankle. We get you imaging, make sure we're not missing anything wrong. Here we did some Epsom salt soaks to increase mobility. We did a lot of homeopathy, any functional brace. And then we talked about shoes. And we got better. We'll be back. Back concussion. This is a vein of my existence. Mine too is. Yep. It didn't hurt. It looks like it felt so good, but it didn't. So, doing all of the standard things, yeah, sure, okay. Here's your pain medicine, here's your T-squeeze, here's how we do normal things. As you get better and you do graded progression back to normal, we do PT and vestibular rehab. But can we do anything else? Can we use homeopathy to decrease our traumatic response, our rate of inflammation, allow our nervous system to try to ramp up? There's some small studies from the PMed literature that talks about using creatine, and we're not talking little bits. We're talking 20 to 30 grams. The only downside to creatine at that level is GI upset. I mean, as long as you have reasonable kidneys. Most folks, they can't tolerate it. Some products you can, some are better than others. Fish oils at 4 to 6 grams per day. This is an old one. This is back from the 80s and 90s when they were looking at what can we do in kids with asthma. If you give them enough fish oils, we actually do get a great inflammatory response. In concussion, we can that same rate of inflammation decrease we can get with some fish oils as well. Is this guaranteed? No. But you're talking about $6 a piece for these guys, and you're talking about maybe $25 to $30 with your creatine and fish oils. You see your osteopath for assisting with structure and function. We talk about acupuncture for fluid motion, and chi, and blue light. If we can decrease the stress from that the eyes take in, can we decrease the stress overall? Can we get you back faster? Nerve injury. Very similar. Similar treatments, similar modalities. Why do we have to just let it rest and mask these symptoms? Because now if I give you things that Dr. Demansky talked about earlier of muscle relaxant pain medicine, what if you are now drowsy or sleepy and you can't perform? What else can we do that can keep you in the loop? Or functioning, that while you get better, training while you get better, allowing you to sleep, allowing you to feel, to have improved overall function, to get better faster. Shoulder injuries. You talked about shoulder injuries. Gosh, this is a tough one. And the reason I say it's tough is it's really hard to get improvement, but we do our best. So homeopathy, osteopathy, acupuncture, focused rehab and homework consistently, BFR, ultrasound guided procedures, whether that's Prolo or PRP. Prolo ends up being very specific. You can drop small amounts of irritant into a tendon injury. If you end up having a shoulder tendon injury, you can use small amounts of your caustic substance. People have lots of things that they like using, whether it's hypertonic saline is one of the older ones, or PRP. I can't tell you there's beautiful data on all of it, but sometimes it's worth a try. Hand injuries. Okay, so, oh shoot, we hurt our hand. I can tell you this was trying to catch. So we were trapeze, we were trying to catch, great, what happened? It'll be fine, no big deal. No, it's not fine. 3-4 weeks later, it's still bad, nothing we can do. So we absolutely cast it, right? No way. There was NSAIDs and immobilization and PT, and they talked about surgery and they saw the providers. No. No way. Did we do homeopathy acupuncture report? No. No way. So what next? This performer continued to participate and thought it would be okay. Eventually, when that didn't work, decided that they probably need to do some sort of mobilization. At that point, that was their only option. And they had a great outcome. Back to function. Took a few weeks, so what happens if we had an alternative to function? And I use this as an example of what if we had functional bracing? What if that same injury, which is currently braced, was allowing that performer to do the same activity? Could they work with their injury without any potential for complication or risk? Could we create a functional splint that gave them what they needed, the support they needed, that didn't affect their health, longevity, or how they functioned in a significant way that they were able to work with? Could this be costume friendly that could be noticed? Could they keep training even if they weren't performing full time, so that when that got better, they were able to be right back in? Lastly, we're going to switch gears for a second. We have a few barriers to care. and I hate this because it's convenient access to care. When you work evening and night work schedules, your normal things at 9 to 5 don't work. They kind of can if you really want them to, but how are you going to get any reasonable care? Okay, so I go see my appointment, and then, oh, you got to make an appointment for an x-ray or an MRI in 2 to 3, 4 weeks at some time during the day, or right before you're supposed to be at show or rehearsal or prep or PT. How's that going to work? The timeline of care. How long is it going to take me to get in? What if it's days, weeks, months? Oh yeah, come see me in 2 weeks. How's that going to help? Does this breed the feelings of health that we don't like? The insurance, and what if it's a huge cost? And then we talked about the distrust, and then how do we work to get this all together? So it's so amazing to hear that there's a consultant with Circus, but is it enough? My argument would be no. Because like we talked about with your failures, part of what allows people to do what they make themselves extraordinary at is the mental and physical being. And I laugh at this because, so in the NFL, which is a $163 billion entity, there are 7 full-time psychologists. There are 7 out of the 32 teams. So even in a place where there is more money than God, we haven't figured it out yet. So I think we need to address this. And they're not the same as all performers do not have the same needs as the general public, nor do they have the same needs as your So Dreamland. Timely, coordinated, comprehensive, performer-specific care. Can we have 24-hour access to performer physicians to quarterback the care, to facilitate imaging, diagnostics, rehab, management process, multimodal treatment options, communication, in addition to everything that's out there currently? How can we be specifically tailored to guide and help in the care of wellness, regardless of the severity? Can it be part of their contract compensation? Can it be part of disability to prolong, if they have prolonged recovery, to prolong the career? I think what we've come to say is the future is really bright. We're here. I can't say it's perfect, but I'm so encouraged by the amazing outpour of information and support. And I'm really grateful to be allowed to talk to you today. Thank you. Any questions? Do you have any for you?
Good. Anybody? Well, with that, the good news is we're going into a break. So I do know that a lot of people have had questions for a lot of other people. We're going into a short break while we set up for the performances of this evening. So if you do have questions, feel free to approach. I guess I'm volunteering all my speakers, I'm sorry. But if you're okay with people approaching you with questions, we're going to take a short break for the next hour or so, just as we set up kind of our aerial rigs and the rest of our apparatuses. And generally right before 7 o'clock, we're going to get ready for our performers to show and talk us through some of the stuff that they're doing. So if we can just give one more round of applause for all our speakers.